Hi, my name is Blanche Krysti. I am the medical director of Telehealth at the Children's Hospital of Philadelphia. Today I'm going to talk about what academic institutions or children's hospitals could think about in terms of sustaining their telepsychiatry program after COVID-19. So I'm going to give the academic perspective as well as the hospital perspective in how to maintain telemental psychiatry or telepsychiatry after COVID-19. First of all, I want to disclose that I do have my own practice on the side. I provide clinical expertise for digital health companies and as well as do telepsychiatry for busy professionals through my company, VoCare. I'm employed with the Children's Hospital of Philadelphia. I'm an advisor at DreamIt Ventures, and I receive development funding from Tiller.org Impact Fund. So first, the agenda today is that we're going to talk about the benefits of telemental health, and then we're going to go in terms of key strategies, and then we're going to talk about operationals and barriers that you can come across and how to mediate that. One of the benefits of telepsychiatry or telemental health is that it has many benefits from the consumer. With telemental health, you're providing access to specialists. There's a reduced cost in transportation and logistical barriers, such as gas mileage save, etc. That will decrease the cost for the patient and their families. You can also provide flexible hours for scheduling appointments, where it can be set for later in the day, in the evening, or in the morning, where families is more convenient for families. And telemental health can provide a continuity of care where it could be inpatient through outpatient as well as care management, and it can serve as throughout the spectrum of care. There's studies published that it has a lot of high consumer and family satisfaction. Another thing that telemental health is very beneficial is that it actually helps the provider as well. It decreases transportation and logistical costs for the provider. There is increased time and efficiency in terms of not having to commute to their office location, fitting patients in those commute times, so that can be seen as increased number of visits and increased efficiency. It can also provide improved communication and collaboration, especially when you are providing a teleconsultative service to primary care as a specialist. You can do teleconsultative services. And it also helps a diverse consumer population, particularly the patients in the rural area where it's harder to reach them. And there's flexibility to work from home. Furthermore, the most important aspect is the impact on the community as a whole, as community instance of the whole mental health system and the healthcare system. Telepsychiatry or telemedicine or teleservices in general can increase access to specialists. It reduces inappropriate admissions and help also improve the organization of healthcare and the increased population health, decreasing barriers for patients, and ultimately impacting population health outcomes. So what are some strategic considerations for a hospital, particularly a children's hospital or an academic institution? One thing you want to consider is, in terms of greater vision, is not thinking too small or not thinking too big. When you think too small, you're thinking, oh, telepsychiatry as more like a Band-Aid, like, oh, we just want to fit a gap in our ED coverage, and particularly this is with COVID right now, could we consider a Band-Aid coverage? So we also don't want to think too big. After COVID, we want to think about what can we pick that can be sustainable and long-lasting and have impact on your healthcare system. If you try to extend telehealth too fast, too big, which is happening right now during COVID, it's hard to sustain. So in the aftermath of COVID, you want to solidify some of your offerings and your services so that it can be more sustainable. And just start with the lowest hanging fruit, meaning the easiest to get buy-in. Whatever it is that is a priority to your institution or to your leadership, and whatever that is helping them the most, whether that is their desire to improve patient outcome, their desire to potentially serve a diverse population, increase their footprint, whatever that is. You want to work with the easiest service to get buy-in. And there's also, think about that program that you're thinking about, and think about its room for expansion. Don't pick a program that may not have room for expansion, particularly expansion for patient volume or provider volume. So the framework of how you pick a program or how you pick several programs to sustain and really make it well is think sustainability, as we mentioned before. Also think about how you can add more resources in the long term. For example, if you want to start with a small pool of provider, think about the possibility of adding more provider. Maybe if you're starting a psychiatrist, think about adding mid-level mental health professionals, etc. Also think about what existing resources you have in your institution, in your academic center, that can be used more effectively. For example, if you have a emergency department, telepsychiatry, that at one site that is low volume, but your hospital can potentially cover, your service can potentially cover multiple ED, then think about how you can shift the operations so that you can use your existing psychiatrists more efficiently. Furthermore, as mentioned, operational pieces is very important to make the existing programs run more efficiently, or you can also develop new programs. In terms of developing new programs, one thing that you can think about is how you can facilitate behavioral health integration, whether that is into primary care or medical inpatient units or community medical homes, nursing homes, geriatric psychiatry, etc. You also want to think about the relationship you have already with other institutions in your area and how to build upon that by collaboration or enhance the relationship. And possibly building new relationship in the community where you can partner for tele services. In terms of partnering, you can get a vendor or a partner to provide some of these services for you, or you can retain your own existing in-house staff. And a pro of using your own in-house staff is that the retention of existing in-house staff may have an uptick, mainly because telehealth is seen as a way to improve work and life balance, and that can be a benefit for staff who are particularly have kids, or they're thinking about starting a family, or especially those who are retiring. A lot of our senior psychiatrists at our institution is going on board to telepsychiatry so that they can be at home, particularly during the COVID-19 where they are at most risk. So part of the strategy is to retain your well-experienced psychiatrists and staff that are getting older and have them be part of telepsychiatry. Another thing is partnering with your own community agencies, local hospitals. That being said, it works a lot better if there is a shared consumer and there's a shared impact on your consumer or patient population. And think about how you can deliver the right level of care at the right time, particularly if the agency or the local hospitals are part of the continuum of care, inpatient, outpatient, IOP, etc. You might want to partner with those institutions that your institution does not have those services. You can think about how telehealth can streamline some of these services together. And think about the consumer. At the end of the day, the patient, the consumer is what we are trying to help. So think about what would they want and how to tailor your program to fit their needs. A lot of consumerism, as it is in our consumer health, consumer product department and industry, they are now moving toward convenience, choice, and empowerment. And the same is happening to healthcare when it comes to consumerism. So a few other strategies, a few other options that you can think about is working with correction facilities. and especially for children, juvenile justice services. You can do forensic psychiatry. You can partner with university to provide offerings for their student mental health or employee mental health. You can partner with mobile crisis units, and you can partner with nursing facilities. Let's go back a little bit and talk about the model of telepsychiatry. How can you finesse using different model of services? Well, there's the on-demand services. That the most common of that is the emergency psychiatry, where a patient comes in, you have a psychiatrist on call, and it's on demand 24/7. And there's also scheduled services where it's what you think of when you go to a doctor. You schedule that appointment, regular outpatient services. There's limited services, meaning it's on demand and scheduled, a mix of both. There's direct to consumer, meaning you bypass a lot of the hospital operations and go directly to having the consumer on the palm of their hand or their laptop connecting to your services. And there's store and forward, meaning most common is Telehealth, where they take a picture and it's stored in the chart and it sends to the dermatologist to see at a later convenient time. Those are different models of how telepsychiatry can be delivered, and you can blend those type of strategies together. And just for the record, when I say telepsychiatry, I'm also talking about mental health. A little bit about CHOP. So the Children's Hospital of Philadelphia is the nation's first children's hospital, and it's built on the foundation of delivering safe, high-quality, family-centered care. And we foster scientific research, and our commitment to our community to improve quality care is a commitment. So within CHOP, and I mean, it may be in your own institution as well, is we wanted to leverage our own resources to meet our own internal needs as a first priority. We have many primary care sites. We have 31 primary care sites that had no mental health services. So we wanted to be able to provide that as initial strategy, initial goal. And then we also wanted to partner with a community for to fit the need of the external mental health needs. So given said, we thought about partnering with the primary care network as one of our partnership, and we also did emergency psychiatry with the emergency psychiatry team, and we also did post-hospitalization discharge behavioral intervention. CHOP has a great number of psychologists who specialize in psychological issues associated with chronic medical issues that our children have. So we have our specialist psychologists deliver behavioral intervention post-discharge from the hospital. So those two programs are what we ran with in our first year coming into existence of our telehealth program. Particularly in the primary care, I want to talk about that model in particular. We did telepsychiatry using its collaborative care model. And that is based on the model that originally came from the Ames Institute from the University of Washington, where one of the goals is to work with the pediatrician and mid-level behavioral health clinician to increase access to behavioral health. And we chose this model because we wanted to leverage our own internal resources. We had a great expertise with our psychologists, and we have great clinical social worker that are already embedded into the primary care network and some of the sites, not all the sites. So we wanted to build on that robust program by working with those embedded therapists and the primary care doctors in those already sites that are in the collaborative care model. And keep in mind that while rural areas and suburbia areas definitely have shown to lack access to mental health, urban areas such as Philly, the proper city of Philadelphia, there's also access issues in urban areas. So how does that model work? That model works by having a telepsychiatrist seeing the patient and the family with the PCP. That is a true well, that is one of the way we thought to do. It's not necessarily the model of collaborative care. It's our own modification to it, mainly because one of our goals was that we want to upskill the primary care doctor. We want to be able to train them and help them do better psychiatric assessments and better training on managing some of the common behavioral and psychiatric issues that children can have. So that was one option. We also have telepsychiatry directly to family and patients as well. So also in terms of ED telepsychiatry, which is one of the programs we start with, one of the pros of doing that strategy and starting with that is that the faculty and fellows who are covering your ED, if you have one, is that they don't have to go in. Perhaps you can start overnight coverage for your on-call doctors and trainees, and it can cover multiple hospitals, as mentioned. And it's also if you're a training institution, it will be a fellows or training recruitment incentives or trainee recruitment incentives by telling them, you don't have to go in for those on-call shifts. And younger physicians care a lot about work-life balance. Furthermore, when you cover ED, you can contract out with psychiatrists in other time zones where they don't necessarily have to work overnight. It's if it overlaps well, you can contract it out where they're covering shifts that other providers can't cover. You can also, another pro of using ED telepsychiatry as a starting point is that you can work with a smaller number of people. If you have many people in your department, ED is a very focused group that you can work with. So in terms of training your physician staff, many insurers actually do require physicians to, or clinicians in general, to attest that they have been adequately trained. So one of the things that you want to start up in your, as one of the first things you should do is to have a training program. Maybe build an online training module to go over regulatory issues, how to do the demos, as well as issues or regulatory issues specific to your institution. And what we did is we had group and individual demos of the technology, and we had people go through our own a set online training module. And keep in mind that in your training, you want to highlight to your physician simple troubleshooting issues, meaning how to make sure you're not on mute, make sure the patient's not on mute, make sure your video is turned on while they're simple. Not many doctors know how to do that, particularly with there's so many of technology platform nowadays. So it's best for you to go over that in your training. Also, during a session, if the patient is not trained, if a clinician is not trained on that, it really delays the start of a session. And if they are trained on how to help the patient with those simple troubleshooting, then it really makes the flow of the clinical day for the clinician and the patient more easy. So a few things to think about training for fellows or trainees, if you have them, is you want to do a pre-go live where part of our training, and we adapted called a program that is a pilot program for training child and adolescent fellow. And so we did a mini clinical evaluation exercise similarly to an OSCE, but not where they can do it with or without live patients, and we test their troubleshooting skills, we test their telepresence, we give them feedback, and then they get approval from the training director. And then moving forward in the next year, we plan to have a didactic series that is embedded into the fellows curriculum that will span the course of 2 years. So other things is there's 360-degree feedback tool that is often used in pediatric training. You can use that on the telepsychiatry as well. Good place to use that is using it in the ED telepsychiatry, where it's multidisciplinary. It's often with pediatricians, it's often with a social worker. So that's something to think about. Training on safety, management, and privacy for both fellows and clinicians and doctors is important. You want to train on the open greeting, verifying guardian phone number, physical location of the patient, ask patient who is home and who is in the home with the patient for privacy concerns, and you want to prompt the guardian that you may ask them to leave, especially in adolescent, for privacy of the clinical encounter. Keep in mind that this open greeting suggestion is our own at the Children's Hospital of Philadelphia. It's not necessarily in practice guideline as of yet, but this is what we thought is fits our own state guidelines and our own institutional guidelines. Also, know the local 911 and the crisis center numbers nearby, and educate your staff on those things. Keep in mind that calling 911 would not work if a clinician called 911. It will not be the same 911 local dispatch as where the family and the patient and the youth is at. For example, if I'm in Philly County and I call my 911, it's going to be Philly County local dispatch, not in Bucks County, 100 miles away. And so the routing of the 911 services is complex, and it's actually not as simple as people think. And it's best to have the family call 911 in case of emergency. So clinician calling 911 goes to their own local 911 dispatch service. So something to think about and for your own institution to look into. In terms of training, further training, is that we have, for our second year, we have an elective, and we give them opportunities to rotate in any of our clinical settings. And you can think about that as well. You can also think about it for medical, if you're affiliated with the medical institution. You can have an educational program for medical students to rotate with your institution, etc. And keep in mind that three-way conferencing is very possible in a lot of platforms. A few operational considerations. So, active partnership is key, particularly if you're partnering with your community agencies or local hospitals. A few things you want to think about is the consenting process, what that is in your state, and whether it can be on paper, whether it can be digital. And so you definitely talk to your legal department, and definitely look into what the consenting process is for your own state. Keep in mind that alternative connection method is definitely needed. You gotta have that backup plan in case a connection is lost. Even in urban area, connection can be lost at time. And so make sure you have an alternative plan well established. As mentioned, emergency management is important. But keep in mind that if the patient is at what we call the original site, which is where the patient's at, particularly if they're at a primary care center, that the protocol should match whatever site they're at, especially if it's not your own institution. And keep in mind that you can do dual scheduling complexity if the patient is in a primary care site clinic schedule and a telepsychiatric schedule, and those are the details that can be worked out in your EMR, and your institution can probably help you with how to schedule things more streamlined. As we go into post-COVID, a lot of people are talking about mixed model. It's definitely okay to do a mixed model of in-person and video. For example, in-person for the first initial evals, video for follow-ups, or in-person for some of the neuropsych testing and maybe follow-up feedback visits through video. There's many ways you can do mixed model, or you can do video visit only. So a few things to consider is if you're working with children, is that who's in the room with the patient, like who assists the family and the patient get connected to the service, and children would require a guardian to consent, and what that process is. And who would be the telepresenter? Telepresenter is a term in the telemedicine world that means someone who potentially takes vitals, who set up the room with the patient, connects the software platform with the family to the telepsychiatrist. So a few key barriers that I'm going to leave you with, and what you could do, And this is up to your own institution. But one of the main things I think is a barrier to a lot of institutions is reimbursement. And this is dependent on each institution contracts with your own payers. With the boom of COVID and payers knowing and feeling the need for telemedicine, telehealth, they will at this time, some of them may agree to reimburse for it. What you want to work with your payer is whether they're going to pay for it after COVID, after the national medical emergency has been lifted, and how you can sustain it. How can you provide proof value and proof impact to your payers and negotiate that. If reimbursement for the telehealth services doesn't work out with payers, just a few solutions or potential thing that you can think about is contracting between other departments and your psychiatry department, or grant and research support funding, or contracting between your institution and other community partners in your community. Very important thing is that we should collect data. Telemedicine, telepsychiatry, while there's been many research articles and many research studies on the use of telepsychiatry, there is still a new area. And so a few things to consider is what data you want to collect. Is it cost saving for your patient? Is it, or your institution or payers? And think about patient, family, or provider satisfaction, and start collecting data, because as much data as we have, we can go to the different leaders in healthcare and different payers to talk about how analyze it and talk about how whether it is or not helping and modifying in such that it truly provides impact to our patient. And as such, you can definitely engage in advocacy, know your institution government relationship office, know your local professional organization. American Telemedicine Association, ATA, is a very good organization to be involved with, and know your representative senators. Write letters, call, and tell them about how your personal experience in this work is, and advocate for a lot of telehealth parity. A lot of states now don't have parity, meaning there is no state policy that requires payer to pay for telemedicine. But so if we ask for them to have telemedicine coverage to cover it, as well as parity, is to have the same reimbursement rate and value as physical medicine. We want to advocate for that, both telemedicine, telehealth parity and coverage in states that don't have it already. In particular, Pennsylvania do not, but other states may. Well, that's it for today, and I hope you found that helpful. Feel free to reach out to me at Dr. DRVO at Vocare, and my website and my LinkedIn. I'm happy to connect through LinkedIn and get to know each other and see if there's any synergies in future collaborations and just pick each other's brain. Thank you very much for joining me.